Good afternoon, everybody, and thank you to SciMed and New Vision for inviting me to give this talk on the clinical use of Omnigen OmniLenz, which expands the options we have in the clinic to manage some of our patients who can present with um, difficult ocular surface conditions. I would like to start by declaring no financial or conflicting interest in this presentation at all. The first work I will present to you today is what was recently accepted for publication on the management of persistent epithelial defects with OmniLenz. This work was done in our unit, corneoplastic unit in Queen Victoria Hospital in the United Kingdom. We looked at the results of managing the persistent epithelial defects in terms of healing as our primary outcome, but we sub-analyzed the groups of etiologies that has led to these persistent epithelial defects. We included 81 patients with a total number of 93 epithelial defects. That doesn't mean two epithelial defects happening at the same time in the same eye, but some of the patients after complete healing might present again with another persistent epithelial defect requiring treatment, and the number of OmniLens applications were 106, and that is because as we were advised by New Vision that Omnigen OmniLenz combination will have reduction in the efficacy after 2 weeks. So we had our protocol of management while we have applied the OmniLens for 2 weeks, and if the defect hasn't healed, we would replace it with another application of OmniLens. So the length of treatment on average was 22 days, and that is in all patients. But in healed patients, the average was 25 days from the start of applying the first OmniLens till complete healing. And although 83 of these defects required only one application, um, some of the defects required more than one, and we had one defect which required 4 applications of OmniLens until complete healing. The mean age of our patients was 55 years, and 52 of the patients were males and 29 were females. A large number of these patients had limbal stem cell deficiency caused by multiple etiologies, but we had a couple of patients who had exposure keratopathy due to thyroid eye disease. We had 15 patients who suffered epithelial defect due to microbial keratitis. We had one patient post PTK, neurotrophic corneas, Fuchs endothelial dystrophy causing corneal decompensation, and epithelial bully and persistent epithelial defects. We had to exclude 3 patients out of our cohort. Two of them had the lens falling off on the first day of application, and one patient passed away during the course of treatment without achieving complete corneal epithelial healing. And because of the various etiologies of the defects, the patients required concomitant treatments like topical antibiotics, mainly in cases of infections, topical steroids in cases with ocular surface inflammation, as in Steven Johnson, or in chemical burns. Some cases require topical immunotherapy in the form of cyclosporin eye drops, or systemic immunotherapy in the form of oral um, steroid tablets or oral mycophenolate to reduce the chance of rejection in repeat corneal grafts. We had 8 defects requiring tarsorrhaphy because of the exposure and the abnormal lid closure, and 18 patients were using plasma eye drops with having the application of the OmniLenz. And the results showed that 58% of the defects had complete healing, while 28% had partial healing, defined as healing starting but failure of complete closure of the corneal epithelial defect. And 14% of the defects did not show any signs of improvement. And 59% of the eyes had improved visual acuity, with 27% were stable and 14% only had worsening of their visual acuity. And while looking at the sub-analysis of the infected cases, 13 of them had bacterial keratitis, 4 had fungal keratitis, 3 were herpetic, and 1 was acanthamoeba. And again, 57% showed complete healing in this subgroup, with 24% showing no improvement and 19% showing signs of partial healing. And in the 16 patients who had persistent epithelial defects following a corneal graft, 56% of these had complete healing and only 13% showed no improvement. And we also had half of the defects with limbal stem cell deficiency showing complete healing and less than a quarter of them showing no improvement. So we concluded from our study that the use of OmniLenz for these indications was safe, and it was good that we could follow our patients on the slit lamp and examine them without the need of removing the lens or the tissue, and we can actually see through with the slit beam because they are transparent enough to be able to comment on the rate of healing, and we had favorable outcomes in helping the healing of the persistent epithelial defects combined with infectious keratitis. And this slide here shows data from Portsmouth Hospital Group, where they treated 12 persistent epithelial defects from various etiologies. All of them were unresponsive to treatment. 58% of these patients were males, and the persistent epithelial defects were ranging in size from 2 millimeter up to total corneal defect, and they have had good results. And the photos there show a case of neurotrophic keratitis. Figure 2 is before treatment, and figure 3 is after 2 weeks of applying the OmniLens, and the defect has completely healed. Only one case has failed to heal because the lens did not stay inside the eye. And while 2 patients experienced recurrence of the defect, all the 11 patients who showed healing had their healing within 6 weeks of the start of treatment. The same group presented a case of a PED, post-penetrating keratoplasty, which failed to heal with standard management, but after applying OmniLens twice within 14 days, the epithelial defect has healed completely. The application of Omnigen is not only to treat corneal epithelial defects, but when we need to apply a piece of amnion to cover the ocular surface beyond the cornea in cases of chemical burns, for example, Stephen Johnson, and larger discs can be applied, and a symblepharin ring can be placed to keep the piece of Omnigen in place. This large diameter disc can be further secured with a suture in the center while it's wrapped around the symblepharin ring to help it stay in the fornices. Also, larger pieces of Omnigen are available in case we need to cover a larger um, defect or a larger area of excessive ocular surface burn or inflammation. And again, that can be secured in place using a symblepharin ring or a bespoke IV tubing, which can be fashioned to need. And this is secured by applying the large piece of amniotic membrane across the eyelids, upper and lower, and securing with a stitch across a piece of bolster. And then the ring, whether it's the symblepharin ring or the fashioned IV tube or cannula line, can be placed to work as a symblepharin ring within the fornix, and then the bottom eyelid would be again having the piece of amniotic membrane covering around and secured in place with a bolster and a suture. And this is a nice case from the University of Nottingham done by Professor Harmin Berdua, where he applied the large piece of Omnigen to cover the ocular surface and the inner side of the eyelids in both eyes of a male patient who suffered acute chemical burn, and because the patient was in an induced coma, there was no need to secure the Omnigen above the symblepharin ring. So symblepharin ring was enough to keep it in place without placing any sutures, and that was changed every 5 days, and the outcome was very good at the end of the management. And here is a range of data on the use of suture-free transplantation of large sheets of amniotic membrane, whether used as a patch or used as a graft, because this is one of the nice functions of using the amniotic membrane or the Omnigen in the office, in the outpatient clinic, or in the eye casualty without the need of ordering tissue and taking the patient to the operating theater. And thank you very much for your attention.